Subcommittee will come to order. The chair recognizes himself for 5 minutes for an opening statement. I have here on the desk this giant stack of every regulation, notice, and correction that the Obama administration has issued so far related to the recent health care law. By count of the subcommittee staff, 370 Obamacare-related items have been issued. Over 3,500 pages of rules, notices, and corrections have been published, many of which were released as interim final rules, bypassing the traditional public comment period and giving them the force of law. I would like to focus on just two: grandfathering of existing health plans and the medical loss ratio, MLR. If you like what you have, you can keep it, was the promise that President Obama repeatedly made on the campaign trail and in the months leading up to the passage of PPACA in March of 2010. If you like your current plan, you will be able to keep it. Let me repeat that. If you like your plan, you'll be able to keep it. That's President Obama with remarks at the White House on July 21st, 2009. If you like your insurance plan, you will keep it. No one will be able to take it away from you. It hasn't happened yet. It won't happen in the future, end quote. President Obama on remarks in April 2010. During the 2008 presidential campaign and the months leading up to passage of the health care reform law, President Obama, his administration, and congressional Democrats made a series of promises to the American people. Whether you supported PPACA when it became law or not, it has become abundantly clear that those promises have been broken. According to the administration's own estimate in June 17, 2010, its regulations will force half of all employers and as many as 80% of small businesses to give up their coverage in the next 2 years. The regulations state, quote, after some period of time, most plans will relinquish their grandfathered status, end quote, meaning American workers will lose the coverage they have now and become subject to PPACA's more costly requirements. A May 2011 PricewaterhouseCoopers survey of employers reveals companies' responses to the new health care law and how many are contemplating eliminating coverage as a result. It also echoes the administration's warnings. Of note, 51% of employers surveyed did not expect to maintain grandfathered health status, meaning their employees would forfeit their current coverage and pay higher premiums due to the health care law's mandates on their new coverage. The report also found that, quote, 84% of companies indicated they would make other changes to their plans, that is, raising premiums and copayments, to offset costs associated with PPACA, end quote. The regulations associated with grandfathering health plans are just one reason Americans will lose the coverage they have, even if they like it. The medical loss ratio is another. Despite the fact that the MLR has been billed as a tool to protect consumers from insurance companies, many states are clamoring for waivers to exempt their citizens from these, quote, protections, end quote. Recently, the administration granted waivers to New Hampshire and Nevada regarding the medical loss ratio requirements in the health care law, on top of the waiver already granted to Maine. 9 other states still have their own waiver applications pending before HHS: Kentucky, Florida, Georgia, North Dakota, Iowa, Louisiana, Kansas, Delaware, and Indiana. In an October 27, 2010 letter to Secretary Sebelius, the National Association of Insurance Commissioners warned, quote, we continue to have concerns about the potential for unintended consequences arising from the medical loss ratio. As we noted in our letter on October 13, consumers will not benefit from higher medical loss ratios if the outcome is destabilized insurance markets, where consumer choice is limited and the solvency of insurers is undermined, end quote. Many companies have also applied for MLR waivers. Perhaps the most publicized was McDonald's, whose 30,000 employees were granted a waiver from the annual limit requirement on their mini-med plans, and yet were still in danger of losing their coverage because they could not meet the MLR requirements. The December 1, 2010 MLR regulation exempted mini-med plans from the requirement for 1 year. after which HHS will determine whether or not to extend the waivers for 2012 and 2013, meaning employees could still be in danger of losing their current coverage. The fact that so many Americans have had to be exempted from the law's protections under waivers or risk losing their current coverage should be alarming to every member of Congress. And this stack, this giant stack, is just the beginning. More regulations are due out in the near future, including the establishment of the Essential Minimum Benefits Package, which will increase premiums and put people's coverage at risk. First of all, thank you to our witnesses today. I would especially like to welcome a fellow Pennsylvanian, Dr. Scott Harrington of the Wharton School at the University of Pennsylvania. And I will, all right, I'll yield back my time. Chair recognizes the ranking member of the subcommittee, Mr. Pallone, for 5 minutes. Opening statement.
Mr. Chairman, I really have to object today on many levels. You know, this hearing has essentially become a farce. There's nobody here other than yourself, myself, and Dr. Burgess. And as much as I love to go back and forth with you and Dr. Burgess, I think that it's important that other members on both sides of the aisle be able to attend. Now, I mentioned to you that because of the fact that we had the full committee hearing this morning, and then we're going to have votes, I understand, as early as 12:30, and then the Democrats and the Republicans yesterday, but the Democrats today are leaving at 1 o'clock to go over to meet the President's request, that it would be virtually impossible to have a hearing today that members would be able to attend. And the fact that only the three of us are here just lends credence to that. So I just think that it's, you know, I was only asking you to postpone the hearing, not because I didn't want to have it, although, frankly, I wouldn't want to have it because I think that the subject is a little absurd, too. I'll get into that. But just the fact that I was concerned that no one would be able to attend. And there isn't anybody here, and we're all going to get out of here at 1 o'clock, and I guess then we're going to go back, reconvene after the President, but then there's going to be more votes. So I just think it's terribly disruptive to the witnesses and to the process, and I wanted to postpone it because I wanted to have everybody to be here, and hopefully some come, but it doesn't look like they're here. Now, the second thing is, you know, again, we're talking about repeal or either not the whole of the Affordable Care Act in this case, but provisions of the Affordable Care Act. I don't know how many times it's now, what, June 2nd, 5, 6 months of just the same thing over and over again. Repeal the act is bad, defund the act, turn it from mandatory to discretionary. I don't know how many times we're going to hear over and over again the same thing. I don't hear really much in the way of any kind of replacement or Republican alternatives that would provide coverage or provide affordable coverage. Again, today our focus is on repealing the provisions that limit what the insurance companies can do. Abundantly clear that the Republicans are in the pockets of the insurance companies and will do whatever the insurance companies want them to do, even if it means at the expense of the public. So anyway, I have 2.5 minutes left. Let me get to some of my prepared remarks. But I really am very disappointed in the way this was set up today and the fact that we keep dealing with the same thing to no avail. The Affordable Care Act was a transformational law that brought protection to patients across the United States healthcare system. We finally were able to put a stop to the incendiary insurance industry abuses and reformed the insurance system. We expanded coverage, reduced healthcare costs, and reduced the federal deficit while building on the private insurance system. We sought after and I believe accomplished bringing better value to consumers' insurance plans and promoting more affordable, comprehensive health care to Americans. Some of the most important reforms made in the Affordable Care Act that are meant to curb the insurance industry bad practices are the same ones my Republican colleagues will attack today. They include the medical loss ratio requirements and rate reviews. Medical loss ratio requirements foster transparency and accountability in how insurance companies spend patients' premiums. They also force insurers to be more efficient in delivering quality health care. I believe that American patients deserve a guarantee they're getting good value for their dollar. When that value is not met, insurance companies should be required to refund consumers. In fact, HHS estimates that up to 9 million Americans could be eligible for rebates starting in 2012, worth up to $1.4 billion, a clear indication there is a real need to hold insurers accountable. Today, I expect to hear from some of our witnesses that this requirement will disrupt the marketplace and limit choices for consumers. They will say we need a transitional period in which insurers can bring their products in line with these requirements slowly and methodically. However, contrary to the naysayers, the law's waivers were put in place for potential disruptions, but it is the states who are the best positioned to examine their own markets and make these determinations. The waivers are much better suited to be response to a specific state condition rather than a one-size-fits-all transition policy. Another important critical reform was the process of rate reviews. Let me be clear, this is not a provision that prohibits or restricts an insurance company from raising their rates, but what it does is ensure that any large proposed increases are based on reasonable cost assumptions and solid-based evidence. And this step is meant to hold insurance companies accountable and provide unprecedented transparency to the healthcare market. Now, while Congress was drafting and debating the Affordable Care Act, the insurance industry was recording record profits. In fact, this year, the nation's largest insurers are entering their third straight year of huge profits. According to the New York Times, insurance companies have reported first-quarter earnings that beat analysts' expectations by an average of 30%. And I've got to be honest, across the aisle, you simply can't argue that the insurance industry has been hurt by the federal health care law. Thank you, Mr. Chairman.
Thank you to the ranking member, and I yield to the vice chairman of the subcommittee, Dr. Burgess, for 5 minutes for opening statement.
I thank the chairman for yielding. I thank you for having this hearing today. Goodness knows we could have had this hearing in the last Congress, and we should have had this hearing in the last Congress. It's well into a year since the signing into law of the Affordable Care Act, so it's high time we look at some of these things. Both sides of the dais will talk about jobs and the economy. We talk about it, we demagogue about it, but the big question is, are we going to do anything about it? Unemployment is at 9%, and it begs the question, why are American employers hesitant to hire new employees? Part of the reason might be, just might be, that in the first year since the passage of the Affordable Care Act, this is what a small business owner confronts when they want to hire a new employee. Is it any wonder that they would stop and look and say, I don't think I can do that at this time. We'll make do with what we have. Now, the burdensome regulations that have been delivered by the United States Congress they stack up, as you can see here, to be almost insurmountable by anyone who's ever run a small business that looks at a stack like this would say, I don't think that's for me. But here's the simple truth. You just cannot be anti-employer and claim to be pro-jobs. It doesn't equate. Now, the Affordable Care Act, my opinion, levies unreasonable demands on employers, manufacturers, doctors, and not only discourages hiring, but encourages employers to drop their employee health insurance. We certainly punish physicians, and we tax industry offshore and out of America. Now, shortly after the signing of this act a year ago, large employers reported that the law would increase costs. In fact, several large employers restated their earnings for the year. That inflamed members of the then majority, and a hearing was called in the Energy and Commerce Committee and the Oversight Committee to call these folks in and make them explain why they were restating their earnings. Document demands were made of these employers, and they produced the documents. The documents were examined, and it turned out that the employers were simply complying with the Securities and Exchange Commission, but some of the information contained within those documents made the then majority, the Democrats, decide not to hold the hearing after all, because what they found was large employers were looking at the data and wondering how in the world it was going to be cost effective to continue to provide health insurance. No employer wanted to be the first to drop this benefit, but there were many who would likely be second, third, or fourth. The strict medical loss ratio regulations are another provision that have proved to be overly burdensome, and not only on businesses but on the states. Currently, 3 states have been given waivers. Another 10 are asking and are pending approval. Now, a state realizes that their market can't comply with the law. How in the world is a person who runs a lawnmower shop going to be able to comply with these regulations? The Affordable Care Act really ought to come with a boxed FDA warning that says the Affordable Care Act, when used as directed, may be harmful to your health. It may reduce your health care and increase your cost. The overregulation incites a sense of uncertainty, which discourages hiring and hampers economic development. Every day we get another announcement about another rule going into effect. Far too many are coming out, and quite frankly, several are coming out with the notice of final interim rules, completely bypassing public comment. That is, the regulations have the force of law without the period of public comment. Now, if my friends on the other side of the dais are serious about getting Americans back to work, one of the first steps should be to loosen the regulatory nightmares that have been imposed by this law. Again, I thank the chairman for calling the hearing, and I'll yield back the balance of my time.
Chair, thanks to the gentleman, and now recognizes the ranking member of the full committee, Mr. Waxman, for 5 minutes for an opening statement.
Thank you, Mr. Chairman. I want to thank all the witnesses for joining us to discuss the important insurance reforms in the Affordable Care Act and their implementation. I want to say a special thanks to Steve Larson, who has become a regular fixture at the where are you, Mr. Larson? Okay, he's going to be on the next panel. He's been a regular fixture at the Energy and Commerce Committee, and we may even have to get him a permanent nameplate. This hearing is intended to cover all of the regulations issued under the Affordable Care Act and those yet to come. It's an ambitious hearing that gives us the chance to review important new consumer protections being implemented by the Department, including rate review, the grandfathering rules, and the medical loss ratio provision. Provisions such as rate review and medical loss ratio provide consumers with protections from insurance company rate hikes and help them receive a good value for their premium dollars. Rate review requires transparency so that insurers are required to justify why premiums continue to increase. Premium increases are a hardship for consumers facing a tough job market and a struggling economy, and they're hard to understand given that insurer profits have risen by staggering amounts. Over the last 10 years, the premium cost of family health insurance has increased 131%. This has led to soaring profits. In just the last 3 years, the profits of the nation's largest insurers have risen over 50%. Rate review gives consumers protections against this kind of abuse. Contrary to the claims of critics, the law works to review rates based on existing state authorities. Some states have more authorities, including the right to review rates and deny unjustified increases, while others merely have transparency requirements. The federal minimum rate review provision provides some consistency across the country and offers an easy-to-understand explanation of premium increases and their justification for consumers. The health care reform law's new minimum medical loss ratio requirement is aimed at protecting consumers and ensuring that their hard-earned dollars are spent on benefits and quality improvements and less on insurer profits and CEO salaries. A number of states have medical loss ratio rules, and the new federal law standardizes the calculations and sets a minimum of value for consumers wherever they live. The calculation allows for quality improvements, innovation, and fraud detection to be counted as medical expenses. Today we'll hear from the association that represents brokers and agents that the medical loss ratio calculations to exclude their commissions. Many brokers and agents provide a valuable benefit for their consumers, but exempting their commissions for the medical loss ratio, in effect, means increasing premiums and overhead expenses for the consumer. It's time to hold insurance companies accountable, particularly in markets such as the individual and small group markets where they have had the upper hand for years. Weakening rules that require them to provide better value to their consumers moves us in the opposite direction. The Affordable Care Act provides a series of popular insurance reforms that have already gone into effect, such as allowing adult children up to the age of 26 to stay on their parents' insurance, eliminating lifetime limits, and prohibiting rescissions of insurance when someone gets sick. These apply to all plans 6 months after enactment, overriding the grandfathering rules because of their importance to families. The dependence up to 26 policy has been immensely helpful in responding to the downturn in the economy. The prohibition of rescissions is responsive to the insurance company abuses and has received bipartisan support. And the prohibition on lifetime limits of benefits is necessary protection for a person with cancer or hemophilia who has nowhere left to turn when he or she has exhausted lifetime maximums. In 2014, these benefits will be greatly expanded, truly reforming the insurance marketplace in the U.S. The market will no longer reward companies that avoid risk and leave some of our sickest with no options. It will be inclusive, accessible, affordable, built on the notion of individual responsibility. It is important that we understand the implementation of these rules, but we need to do so in a constructive manner that serves our constituents' needs. We should all want a future where the insurance marketplace is healthy, competitive, and providing quality care. I yield back my time.
Chair thanks the gentleman. Concludes opening statements. We'll go to the first panel at this time. I'd like to thank the witnesses for agreeing to appear before the committee, and we'll introduce them. Randy Reichel is a counsel at Mitchell, Williams, Selig, Gates, and Woodyard, PLLC, and is testifying on behalf of America's health insurance plans. Scott Harrington is the professor of healthcare management and insurance and risk management at the Wharton School at the University of Pennsylvania. Janet Troutwine is the CEO of the National Association of Health Underwriters. Catherine Hayes is an associate research professor at the George Washington University School of Public Health and Health Services. Ethan Rome is the executive director of healthcare for America Now. Edward Finsholt is the senior vice president for the Lockton Benefits Group. And Terry Gardner is vice president for policy and strategy at the Small Business Majority. Your written testimony will be made a part of the official record. We ask that you please summarize your testimony in 5-minute opening statements, and we'll go in the order that our witnesses were introduced. Ms. Reichel, you're recognized for 5 minutes opening statement.
Thank you, Chairman Pitts, Ranking Member Pallone, and members of the subcommittee. My name is Randy Reichel, and I am an attorney with the law firm of Mitchell, Williams, Selig, Gates, and Woodyard. I'm here today as outside counsel to America's health insurance plans, and I thank you for the opportunity to testify today about the unintended consequences and the regulatory burdens of the medical loss ratio requirements under the ACA. I think it's really critically important to examine this provision and the Department of Health and Human Services regulation that implements the MLR provisions. The requirements, the way they've been implemented, impose an unprecedented new federal cap on administrative costs of health plans and strictly micromanages the plan's abilities to invest in new initiatives and innovations to benefit their members and enrollees. There likely will be a number of unintended consequences for individuals, families, and employers, and there are a number of reasons for this. The first is the lack of a uniform transition period. Most states today either don't have medical loss ratio requirements in the large group, small group, or individual markets, or the ones that do have medical loss ratio requirements that are crafted to incorporate existing actuarial practices in order specifically to avoid any type of market disruption. Without the time to make the adjustments and the changes that are needed to comply with the MLR provisions, some of the health plans in the marketplace today have no choice but to exit the market. And, you know, we know that we're not crying wolf about this. And the reason that we know that is HHS has already acknowledged in its letters to Nevada, in its letters to New Hampshire, when those two states asked for a waiver of the MLR requirements, they conceded that the MLR standard could in fact lead to a destabilization of the individual market in those states. And while the MLR is problematic across the boards for all types of health insurance coverage, I think it's important to look specifically at the impact that this may have on access to high deductible health plans. And there's a reason for this. On a per enrollee kind of basis, these options are intended to have a much higher deductible, and they're lower cost to the individual. So as a result, the loss ratios are higher because the administration of these plans doesn't cost us any less. So the premium is lower, the administrative costs are higher, and the MLR, by not taking the kind of differences or special circumstances of these plans into account, really provides a significant challenge to the companies that write this business and make it really questionable whether or not the individuals who have this very popular, very affordable option are going to be able to continue to either obtain it or maintain policies that they have going forward. Even more than that, one of the things that we're really concerned about right now is that the MLR requirements do, in fact, turn back the clock on any kind of efforts to improve quality and prevent fraud and abuse. And they do this for two reasons. One is they only permit dollar recoveries from fraud programs to be counted toward the MLR, but they penalize companies for actually preventing fraud in the first place. And they don't recognize as quality the expenses of transitioning into the ICD-10 coding system that's intended for disease eradication and quality. By having only 4 categories that qualify as quality categories, the MLR requirements inhibit any kind of innovation by capping expenses for real quality programs that may fall outside the very rigid guardrails of those 4 quality categories. The way the regulation is structured, I think, is going to be very problematic moving forward. And the most telling thing is that while the MLR is intended to put a cap on administrative costs, indeed the MLR itself is going to increase administrative costs. There are a host of new reporting requirements that companies have to undergo in order to comply with the new regulations. The companies are going to have new data collection, new accounting, new auditing, and the staff and the ramp up for all of these things. We've talked to AHIP members, and preliminary estimates from at least some of the larger multi-state plans have put some of their preliminary compliance costs at more than $20 million.
Could you wrap up, please?
And then I don't want to repeat what else is in our testimony. We do have some recommendations to mitigate the harmful impact of the medical.
Ranking Member Pallone, Mr. Burgess, I'm pleased to testify on rate review and minimum medical loss ratio regulation under PPACA. These regulatory schemes entail costly, complex bureaucratic interference with insurers' legitimate business decisions and with state regulatory prerogatives. They're not going to increase competition or improve the availability and affordability of health insurance. The rate review scheme will not enhance consumer choice or significantly lower premiums. It will increase insurers' costs and risks, reducing their willingness to expand coverage or offer new products, and ultimately undermine their financial soundness. The minimum medical loss ratio scheme is going to distort insurers' legitimate operating decisions, including some actions that would help reduce costs. Without significant waivers, it'll destabilize some states' markets. It represents a significant move towards government micromanagement of health insurers. It's desirable to replace the rate review and medical loss ratio regulations with pro-competitive forms, encouraging state adoption of policies that promote truly informed competition and consumer choice. In my remaining few minutes, I want to focus on rate review. The Act does not authorize HHS to explicitly approve or deny proposed rate changes, but it requires individual and small group health insurers to justify, quote, unreasonable, unquote, rate increases either to state regulators if the states pass muster with HHS for having reasonable, effective review, or otherwise to the HHS. The complex HHS regulations initially specify a 10% threshold for determining whether or not a rate increase is potentially unreasonable and requiring additional justification. State-specific thresholds will likely begin in 2012. Any insured that goes ahead and tries to implement a rate increase that's held to be unreasonable will be publicized and most likely publicly condemned. It also can be excluded from participation in the exchanges. The law grants monies to states to enhance their rate review. It grants monies in the future to states that have prior approval rate regulation or adopt such regulation, further promoting direct price controls on health insurance. These provisions reflect the views that competition and prior state regulation did not adequately discipline health insurers' expenses and profits. But health insurers' expenses and profits are not significant drivers of high and rapidly growing health insurance costs. According to the National Health Expenditure data, for example, the estimated annual private health insurance medical loss ratio, the ratio of medical costs to premiums, including self-funded plans, has averaged about 88% since 1965, ranging from 85 to 90% with little or no trend over time. Now, there's a lot of variation across companies. Health insurers' profit margins typically average 3 to 5% of revenues, lower for not-for-profit insurers. Administrative expenses average 11 to 12% of premiums. Market concentration is often relatively high at state and metropolitan levels, but it varies widely across regions, and that does not imply adverse effects on consumers. State oversight for individual and small group health insurance of rate changes is very diverse and in many respects similar to automobile and homeowners insurance regulation. The Act's rate review provisions establish significant federal authority over rate increases and those state review process. These provisions and their implementation will further politicize insurance pricing without enhancing consumer choice, increasing quality, or lowering costs. Research has not provided detailed evidence on health insurance rate regulation, but the adverse consequences of binding rate controls, politicization of insurance pricing have been aptly documented for automobile insurance, workers' compensation insurance, and more recently, homeowners insurance in catastrophe-prone regions. There's no reason to believe that requiring prior regulatory approval or tighter review of health insurance rates will be any different. A large body of research indicates that rate regulation cannot and does not lower insurance rates without reducing coverage availability or causing exit by insurers. Analyses of automobile insurance, for example, have found no consistent difference over time in premiums relative to loss costs in states with and without prior approval, but prior approval rate regulation has been associated with less coverage availability, short-run rate suppression, increased market volatility, and increased insurer exits. In short, the rate review and MLR provisions are unnecessary and counterproductive. It would be better to repeal these provisions and replace them with pro-competitive regulation and disclosure at the state level. Thank you.
Chair thanks, gentlemen, and recognize Ms. Troutwine for 5 minutes for her opening statement.
Thank you. My name is Janet Troutwine, and I'm the CEO of the National Association of Health Underwriters. NAHU is the leading professional trade association for health insurance agents and consultants, representing more than 100,000 benefit specialists nationally. I'm here today to tell you about a desperate economic situation that has developed over the past 18 months. It's caused real people to suffer real harm. This dire situation was triggered by the issuance of the interim final rule on medical loss ratios. Since the rule was issued by the Department of Health and Human Services on December 1st, 2010, health insurance carriers across the country have been forced to cut administrative costs to comply. One of the first places that was hit was agent commissions. Now, in reality, agent commissions being considered an insurer expense is really not even accurate. The consumers who purchase health insurance coverage are the ones who hire and can fire their brokers, not insurers, and independent agents pay 100% of their own business expenses. Whether accurate or not, the interim rule categorizes commissions as an insurer expense, largely because these commissions were not specifically listed as an item that could be carved out of the MLR calculation, as were taxes. And as a result, our members report that most health insurance carriers changed commission rates as of January 1st, 2011, the date the MLR rule became effective. These commission changes have already decreased many of our members' incomes by 20 to 50%. About 3/4 of the members of my associations are principals in their own small businesses and employ multiple individuals from their communities. They operate in every state and in every community, large and small. As a direct result of the new law's provisions, these individuals are reporting that they're being forced to reduce services to their clients, to cut benefits to their employees, and eliminate jobs just to stay in business. And in some instances, they're reporting they're just closing their doors. This means that in the future, unless something is done, there will be far fewer health insurance agents to provide for consumers' needs. Now, some of you have probably never had the good fortune to work with a broker, and you may not understand what this really means for consumers. So I'd like to tell you a story that illustrates what I'm talking about. This is a story that I know well, and I know it because I personally experienced it. I'm here today not just as the head of an association, but as someone who knows the people who have been affected. And before I came to NAHU, I was an insurance broker myself for almost 20 years in Texas. I had a large number of clients that I built up over many years, and I did that by providing them great service and benefits at the lowest possible cost. I promised them that I would help them with any issue that came up relative to their plan. And I'm proud to say that during the 20 years that I was in business, not a single one of my clients or a single one of their employees or dependents ever had to go to appeal on a claim. And that's because we took care of issues before it required that type of action. And I want to tell you quickly about one situation that I remember in particular, it's hard to forget a situation like this. This particular employee had AIDS, and his health plan had already paid out hundreds of thousands of dollars for traditional types of treatments, and none of these had really been effective in preventing the progression of his disease. He came to me in desperation because his doctors had given him 6 months to live, and he said, look, I've done some research and I found this one treatment that I really want to try, but he wasn't able to go through with the treatment because it was considered experimental by his plan. After a lot of work negotiating with his health plan as well as the providers for his treatment, we got that treatment covered because we knew how to do it. And he would never have been able to do that on his own. It was difficult to do, but we managed to make it work. You might think that this kind of service would be very expensive. The fact is that most agents and brokers just really don't make a lot of money. The Bureau of Labor Statistics says that the average for agents and brokers is $45,000 to $62,000 a year. Entry-level agents only make about $25,000 a year, and this is before the cuts that occurred on January 1st. So you can understand the desperation of the situation that we're in, and none of us would find it very easy to take those types of cuts. There is a simple solution. We have, as many of you are aware, Representatives Mike Rogers of Michigan and John Barrow of Georgia, both of whom serve on this committee, have introduced H.R. 1206, the Access to Professional Health Insurance Advisors of 2011. Currently, it has 85 bipartisan co-sponsors, 21 on this committee. And I realize that I'm out of time, but I would like to ask for your immediate consideration of this legislation. It is a reporting change, but it's something that would provide immediate relief to many, many people across this country. Thank you very much.
Chair thanks, gentlelady, and recognizes Ms. Hayes for 5 minutes.
Thank you, Mr. Chairman, for giving me the opportunity to be here today, and also members of the subcommittee. The last time I was in this room was 20 years ago as a 20-something health staffer for a member of the health subcommittee, Mickey Leland from Texas. And knowing that Mickey was first a Texan and second a Democrat, it's nice to see that Texas is still well represented on the subcommittee. Today, I'm here to talk to you about insurance market reforms generally and the impact on individuals and small businesses. I am a professor at George Washington University, and my research focuses on implementation of the health reform bill. This committee and subcommittee has a really long history of working to protect low-income, not only low-income individuals, but individuals in the small group and individual non-group health insurance market. Chairman Bilirakis, subcommittee chairman, former, and Chairman Tom Bliley put together the Health Insurance Portability and Accountability Act, which laid the foundation for the Accountable Care Act. What it did was preserved McCarran-Ferguson and allowed health insurers, or allowed states to regulate health insurance with certain minimum federal standards. And the reason Congress stepped in and did that, it was after health reform failed back in 1993 and 1994, was they saw the burden and the dysfunctional markets in the non-group or individual and small group health insurance markets and wanted to step in to do something. And the Affordable Care Act insurance market reforms really build on that. And it's important to recognize, too, that both parties, when the debate began in healthcare reform, were supportive of these insurance market reforms. Although their views of it were different, both were very concerned about individuals and small groups. The problems in the small group market are well documented. Although health insurance plans are prohibited from denying coverage for small groups, for small businesses, they can charge whatever they want. And quite frankly, some states, although some states have implemented rate bands to limit that, generally in some states, small businesses can pay a 100% surcharge because of the risk, the high-risk individuals that they employ. The Affordable Care Act was really laid out in two phases if you look at the statute itself. One, there was envisioned a transition period that began with date of enactment, ending in 2014 when most of the insurance market reforms went into place. There were a number of experts, insurance experts and regulators, came before Congress and told members of Congress that, yes, it's very important to reform these markets, but you need to be careful. You need to phase in things slowly, you need to build in protections, and the Affordable Care Act does include that. Some examples of the protections and the transition rules that were put in to the Affordable Care Act include grandfathering of health insurance plans. They include high-risk pools, small business tax credits, and the insurance market reforms, which include the immediate reforms, annual limits on coverage and coverage of dependent children, as well as medical loss ratios. In a review of the regs, it is easy to see the administration is following the pattern that was set out in the Affordable Care Act, which is namely to get through the transition period to full implementation in 2014. Ultimately, small businesses have quite a lot to gain under the Affordable Care Act. They will be able to purchase health insurance coverage through exchanges, they will have options, and they will be able to pool both risk and some of their administrative costs. And finally, even those small businesses that choose not to provide health insurance coverage for their employees, because for the smallest businesses, there isn't a requirement to provide coverage at all, their employees will benefit from the tax credits in the Affordable Care Act and can purchase through the exchanges. At the end of the day, this will benefit small businesses because their employees will be insured, they'll have less absenteeism, and ultimately those with health insurance coverage have better health outcomes and better health status. In conclusion, Mr. Chairman and members of the subcommittee, the Affordable Care Act has tremendous potential to lower costs for small business and to make their health benefits competitive with large businesses, an important factor in recruiting and retaining a workforce. Thank you very much.
Chair thanks gentlelady and recognizes Mr. Rome for 5 minutes for his opening statement.
Mr. Chairman and members of the committee, thank you for giving me the opportunity to testify today. Healthcare for America Now is the nation's leading grassroots advocacy organization on healthcare and a strong supporter of the Affordable Care Act. The ACA includes many sorely needed market reforms, consumer protections, extended coverage provisions, and cost savings that are already benefiting millions of Americans. While much of the country is still struggling in this tough economy, health insurance companies have posted record profits with premiums that are crushing America's families, seniors, and businesses. That is why the provisions of the law that hold the insurance industry accountable and end their worst abuses and curb unreasonable rates are so critical. Thanks to the law, We have a new MLR rule that's been discussed that requires that insurers must spend on actual medical care a specific amount instead of on wasteful overhead, excessive profits, and bloated executive compensation. The MLR combats the long-term downward trend in insurers' spending on medical care as a percentage of premiums. While the MLR was about 95% back in 1993, it is 80% or less amongst large insurers today. That's thankfully changing already. The new rule is already cutting rates for some consumers, like Aetna subscribers in Connecticut, an intended consequence of the MLR. And it promises up to $2 billion in rebates nationwide if insurers fail to meet the new standard. We also have the rate review regulations that have been discussed, which will substantially reduce rates as well. We've seen over the last year several examples where the intervention of insurance commissioners have already reduced rates. Aggressive rate review is imperative given the sharp rise in premiums, as has been discussed. 114% over the last 10 years for families with unemployment-based insurance, 3 times greater than wage growth. And while insurers blame these increases on the rising cost of medical care, premiums have been going up at double the rate of inflation, of medical inflation. The big driver is profits. The Wall Street run health insurance companies, their profits jumped 51% from 2008 to 2010. In 2010 alone, their combined profits were $11.7 billion, up from $9.9 in 2009, despite a 4% decline in enrollment. New data indicate they are on their way to record profits in this year as well. But reported profits tell only a fraction of the story. Insurers have also amassed a capital surplus that vastly exceeds the nation's major for-profit and nonprofit, what they are required. According to a Citigroup analysis, the nation's major for-profit and nonprofit health insurance companies held an astonishing $93.3 billion in total risk-based capital to cover unexpected medical claims as of December 31st, 6 times more than necessary. And virtually unnoticed by many, the for-profit insurers have steadily moved billions of dollars of cash off their balance sheets to buy back their own shares on the New York Stock Exchange. This increases profits and share prices. It does nothing to improve patient care or the quality of their programs. The profits are astonishing. Their CEO pay is breathtaking. But what is galling and unacceptable is that the insurance companies impose double-digit premium hikes on America's families and businesses year after year to pay for these excesses, and they do so at a time when our families and businesses simply can't afford to pay more. And it's clear these rate hikes are not justified. They could reduce rates by dipping into their capital surpluses. They could reduce rates given that utilization is going down. 2 final quick things. We should not be spending our time talking about how to undermine the Affordable Care Act. For example, taking broker commissions out of the MLR equation. What that will do is jeopardize $1.4 billion in rebates for consumers. And as rates have gone up 100% over the last 10 years, so too have the commissions of brokers. We can also increase rate regulation by expanding rate review by enacting the Health Insurance Rate Review Act, sponsored by Representative Schakowsky and Feinstein, which will give HHS greater power to review rates. America's families and small businesses desperately need relief. With aggressive implementation of the ACA, the days of health insurance price gouging will come to an end. Thank you very much.
Chair thanks the gentleman and recognizes Mr. Fenschultz for 5 minutes opening statement.
Chairman Pitts, Ranking Member Pallone, members of the committee. My name is Edward Fenschultz. I'm a Senior Vice President with Lockton Benefit Group, headquartered in Kansas City, Missouri. Lockton Benefit Group provides employee benefit consulting services primarily to middle market employers, about 2,500 of them from coast to coast. Most of those self-insure their health care coverage. That is, they pay claims out of their general assets fewer than half buy group insurance from insurance companies. Mr. Chairman, that stack of papers to your right has been my life for the past year. My job, day-to-day job, is to run Lockton Benefit Group's health reform advisory practice, where we steer our clients through the maze of regulations and rules. And I might add, Mr. Chairman, that that stack of regulations and rules is not only a burden on small business, it's a challenge to our clients in the middle market and to large employers as well. If I could sum up the views of our clients regarding the health reform law in a couple of words, those words would be frustration and bewilderment. The men and women who run these companies and supply jobs in their communities provide valuable health insurance benefits to their employees, but they struggle to do that. They struggle with the financial aspects of that coverage and with the dazzling array of federal rules and regulations they must navigate in order to provide that coverage. For example, today, as we speak today, there are more than 50 separate notices, disclosures, and reports to the federal government that a health plan sponsor must make just for the privilege of sponsoring a group health insurance plan. Never mind their notices on their 401k plans, their OSHA notices, their EEOC notices, EPA notices, whatever. A simple health care plan has north of 50 notices, disclosures, and reports it might be required to supply under federal law alone. 19 of those have been added by the health reform law so far. These obligations impose additional hassles, headaches, and costs to our clients and subject them to onerous penalties for failure. The health reform law adds a variety of new benefit and coverage mandates that add additional costs and complexities to the sponsorship of a group health insurance plan. Our clients understand why Congress would act to supply access to health insurance for those who do not have that access or cannot afford it. But they simply do not understand why, in a time when everyone agrees that health insurance and health care is too expensive, why Congress would act to make the provision of employer-sponsored insurance, through which about 150 million of us obtain health insurance today, more costly and particularly more hassle-prone. We recently finished a 12-question survey of our clients on the impact of health care reform on them and the plans they sponsor. Over and over, we received the same responses we've been hearing orally from them for the last year. Comments such as these, taken verbatim from our survey results. We currently provide health care coverage to our employees. The Reform Act will do nothing but add cost and add administrative requirements. The law is burdensome with little benefit to employer or employee. In the long run, the law will reduce access to health care services and dramatically increase the cost to both the employer and the employee. What they, meaning the Congress, are planning is only going to penalize the employers and the employees who actually are hard workers and who are trying to make a living for themselves and not relying on the government to take care of them. The law includes a grandfather clause ostensibly intended to shield existing group plans from the law's costly mandates and other provisions, but it is a porous shield indeed. It supplies no protections from several requirements, such as the obligation to eliminate lifetime and annual dollar maximums that plans have used for years as reasonable cost containment measures, or the obligation to supply coverage to adult children, even if married, even if non-dependent upon the employee or living apart from the employee and his spouse, or even if the child is gainfully employed himself or herself. The grandfather shield does protect plans from other mandates, but the grandfather protection is so easy to lose as a result of routine plan design changes that the vast majority of our clients lost grandfather status immediately. In our survey, 18% of our respondents said they would consider eliminating group coverage in 2014. To be fair, few have said they will do it for sure. Few have said they will definitely maintain coverage. Mostly they say, we will wait and see. We may not be the first to cancel our group plan, but we will not wait to be third either. In closing, let me say it simply seems to us and our clients that if Congress were inclined to attempt to address health insurance access issues, it should not punish employers in the process. Our clients are not the bad guys. They don't understand why this law makes their provision of group health insurance more burdensome and more costly rather than less so. Thank you, sir.
Chair thanks gentlemen and recognize Mr. Gardner for 5 minutes for opening statement.
Thank you, Mr. Chairman. Good afternoon, Chairman Pitts, Ranking Member Pallone, and members of the subcommittee. My name is Terry Gardner. I'm working with the Small Business Majority, and we're a nonprofit national group advocating for small business owners out there. We represent the 28 million small businesses, which many of those are self-employed, and businesses from 1 to 100 employees. And we do scientific opinion polls and economic research to try to understand what the problems and the solutions that small businesses need. I myself started as a self-employed commercial fisherman for many years in Alaska until I got one of those entrepreneurial ideas to start a bigger company called Silver Lining Seafoods in 1981, and spent the next couple decades as an owner and CEO of that company, growing it from startup to 100 million in sales, 1,000 employees, and selling globally in 22 countries. So I've been through this, as many of the other people in Small Business Majority have been, of being out there and dealing with health care and access to capital and all these issues that all small business owners have to navigate to survive and be successful and create jobs. So we're well aware that many times there are regulatory burdens, lots of reports to fill out there. But I think with health care, we've also watched for decades and endured while it only got worse. And so we've felt that something has to be done. And there is a legitimate role for government to step in when things are only getting worse, as we've seen over the decades with costs going up and less availability, and over half our small businesses don't even offer anymore. So when we survey small business owners, what we find is that cost is really the biggest concern. Our research showed an average of 86% of small business owners cite cost as their biggest barrier. A major economic study we did found that small employers would pay $2.4 trillion in increased health care costs through the next decade if nothing changes. And in fact, we would lose 178,000 jobs and $52 billion in profits with no reform. This is why we have the Affordable Care Act, is because that was the status quo. We needed to do something. And one aspect that we're here to talk about today is the medical loss provision. And certainly insurance companies and brokers have a stake in this. You've heard about that. But I think you need to remember that employers are paying the bill. Small employers are paying the bill in the small group market. Self-employed people are generally purchasing in the individual market, and all of these dollars and costs we're talking about pass through. And so whether the MLR is effective or not is really going to come out of the bottom line of small businesses. And whatever small businesses pay in more and more costs is really going to reduce their ability to expand their company, create jobs. And if we want small business to continue to create 70% of the jobs, then we need to be thinking about this. So we need to work out some of these problems, but we need to make sure that the MLR is protecting the small businesses. Because what we hear in meeting after meeting is small business owners staying up saying, I got a double-digit increase this year on top of one last year. That should really be our focus. What are we doing about that? In general, these small business owners are paying 18% more than the larger business owners. So the other thing we're here to talk about today is the rate review. And really what we're talking about here is transparency. As it's been pointed out, there's no real hammer of the federal government to do anything about it. But again, this is something that as a small business owner, you never get an explanation of why the premiums have gone up double digit. You're just told this is the way it is by your broker. And we certainly support brokers. I always used a broker. Everybody I know use brokers. They're an integral part, and we believe they'll be a very important part in the exchanges going forward. But again, somebody has to pay the bill. And if we just continue to shrink and shrink the number of small business owners because of double-digit inflation, that'll be a reason, that insurance companies' business shrinks and brokers' business shrink. So I'd just like to conclude by saying I think these are important parts of overall health reform. We need to get on with the show and implement the exchanges and the tax credits, and if anything, expand those tax credits along with these regulatory reforms so we can bring the cost down of health insurance for small businesses.
Chair thanks the gentleman. That concludes the opening statements. We are presently in a vote on the floor. There are 7 votes scheduled. So with the appointment at the White House at 2 o'clock for the Democratic members, we will recess for questions of this panel until 4 o'clock. If you can stay, we would like to ask that you can do that. And recognize the ranking member who wants to express himself.
Well, Mr. Chairman, I mean, this is the same thing that I said at the beginning. I told you so. I think that the way we're proceeding is just not good. I mean, there's almost nobody here other than, the 3 of us, and I see that we were joined by 1 colleague on either side of the aisle. But I just think that most of the members have been discouraged from being here because the panel is now spoken. The questions are going to come later. We're going to have a second panel after that. I don't know what time. And I don't know what you're supposed to do now. I guess you have no choice. But I just want to, again, object to the fact that we're proceeding this way. I think it's not good for the witnesses because they have to wait around for us to come back 4 hours later. And the result is that the members are not here to participate. So I don't know what to say. I mean, I keep saying the same thing over and over again. I just hope this is the last time that we proceed in this way because it's just not conducive to a good debate, frankly.
I regret it's unfortunate we have to postpone the hearing. We will make a call to all the members to be back in 3 hours at 4 o'clock and ask the indulgence of the witnesses if they can return at that time.
Mr. Chairman, can I ask what we're going to do about the second panel?
I think perhaps on the second panel we're going to have to delay the second panel for another day.
Well, again, I don't see why.
He's limited on his time constraints at the end of the day.
So I understand that, but we knew that from the beginning, and now we're going to end up having the hearing when we come back after recess. My original request was that we postpone it till then anyway, so now we're going to have to postpone it. It just seems like the whole thing could have been handled better. We could have just had it when we came back and everything would have been straight through and members would have been here. Now we're going to have a second hearing when we come back, and it just seems like, let's just hope that this doesn't happen again.
Unfortunately,
please.
we've got to work around the President's schedule, and I regret that, but we'll reconvene, we'll recess until 4 o'clock.
How many companies do you got?
About 25 minutes.
So are you the region?
The subcommittee will come to order, and I will now begin questioning and recognize myself for 5 minutes for that purpose. Let me start with Ms. Troutwine. You talked about the dire situation facing brokers across the country. Do you believe the reduction in income and employment for agents and brokers as a result of the MLR rule will make more Americans dependent on Medicaid and the health coverage subsidies from PPACA? If so, would you elaborate?
Yes, thank you. Well, certainly, as I testified earlier, if you look at what the average income of agents and brokers are today already, it's easy to see that many of them would be in the category where they would, if they were not insured through an employer-sponsored plan, already be eligible for subsidies. And certainly, with a reduction of 20 to 50%, that absolutely would put many of them down into the Medicaid levels, particularly when you consider the expansion of Medicaid that's associated with the law. So yes, I would say that many of them no doubt would definitely qualify for subsidies, and many of them would also qualify for Medicaid if this is not turned around.
Now, some argue that insurance agents add no value to the system and are simply overhead in the system that can be eliminated at the stroke of a pen or a regulation. Elaborate a little bit on the role agents play in the healthcare system, please.
Well, the first thing I'd like to say there is that, agents and brokers have been used for 100 years to help people purchase health insurance coverage, and they've been used by carriers, insurance carriers, for a reason, and it's because it's efficient. And from time to time, and I've been in the industry 30 years, I've seen carriers say, look, we're going to try to get lean and mean here, and we're going to use our own people, and invariably it doesn't last very long. Usually it's a year or less, and they're back to using agents and brokers because it's more efficient, because they get a larger number of people enrolled, and they're able to do it at a lower cost. Then you have the service aspect, and you have the service aspect, which I talked about earlier, and I gave you one example, but those types of things happen all the time, every sort of claims situation that you can imagine. And this is all at a time when it's taking much more time for them to do their jobs because they have so many questions about the new law, particularly from their employer clients. And for their small employers, they often serve as their HR department. You would be surprised all the things that they actually do.
Thank you. On the issue of fraud, Ms. Reichel, a 60 Minutes episode last year pegged the amount of fraud and abuse in the Medicare program at more than $60 billion a year. Some have estimated that it might be closer to $100 billion. Do you agree? Does anyone disagree that the amount of fraud and abuse in the Medicare program could be as high as $60 billion, as 60 Minutes reported?
I have seen that number on the 60-minute report, yes. And I know that is accurately what they have reported.
Now, using that small number of $60 billion, that's about 12% of Medicare spending per year. Using the higher number of $100 billion, the percentage is about 21%. Would a private plan be able to stay in business if 12% or 21% of its claims were the result of fraud and abuse?
I think it would be quite difficult for them.
Will the MLR rule hinder plans' ability to stop fraud before it happens? And if plans are forced to pay more fraudulent payments, will premiums increase?
And that's really an excellent question. The way the MLR is structured, plans are not going to be able to get credit for preventing fraud. Fraud prevention activities are categorically excluded from the medical loss ratio, and the only thing that plans can get credit for is the dollar amount that they have actually recovered after the payments have already been made and services that are potentially fraudulent have already been rendered.
And I only have 30 seconds left, but Dr. Harrington, I watched your reaction when someone else was testifying about the excess profits. Would you care to comment on your reaction to the testimony of the excess profits the insurance companies make?
Two quick things. I think whenever I look at profits, I tend to look at profit margins because this is a big country with a big industry, and if you look at dollar amounts, they're big. They can be big dollars and a small percentage of total premiums. I apologize for my reaction. My reaction was really to the issue of insurance companies allegedly holding all this capital in excess of what's required by regulation. I've done a lot of work on insurance company capital requirements. Regulatory requirements are the very bare minimum to keep regulators from taking over the company. And to me, it makes really no sense to start comparing the amount of capital a company holds compared to that regulatory requirement as some measure of how much money it could disgorge to its policyholders. The leading health insurers typically have financial strength ratings from rating agencies in the neighborhood of A to A-. They're not A+, they're not A++. So certainly the rating agencies that are evaluating their solvency do not regard the amount of capital they're holding as excessive relative to their responsibility to meet unforeseen contingencies to their policyholders.
Thank you. My time's expired. Chair recognizes the ranking member, Mr. Plone, for 5 minutes for questions.
Thank you, Mr. Chairman. I'm going to ask Mr. Rome, your testimony notes that from 1999 to 2009, health insurance companies raised premiums 131%, 3 times the growth of wages and 4 times the rate of overall inflation. And one of the regulations that Republicans are attacking here today is the so-called rate review regulation, which I think requires very little of health insurers. It only asks that they provide a justification to HHS for any premium increase of 10% or more. Insurance companies with that amount of rate increase will be identified on a public website. I mean, it seems to me that this is the least we can do to try to stop excessive premium increases. So I just wanted to ask you, what more can you tell us about the state of profitability of the insurance industry today? Is rate review going to be an impossibly onerous burden for the insurance companies to meet? Have you seen an impact from rate review on premiums in any states in which it's been implemented so far?
Rate review does a couple of very important things. One is it brings transparency to this process. And if insurance companies are selling a good product with good rates, data they can defend, no problem having it, ought to be no problem having it taken a close look at. Rate review, which just today the California Assembly passed and it's on its way to the Senate, the good example there is auto insurance. They have had rate review since 1988. Prior rate approval. There is a robust and competitive market, but it has brought down rates. In just the last year and a half, aggressive intervention by regulators has reduced rates in multiple places with health insurance. And so anytime you see rates getting reduced in Massachusetts from 18 to 10%, et cetera, you know that those rates have some room and regulation helps find it.
The second question is, you mentioned, I think, or someone at Aetna, that Aetna recently announced in Connecticut, Aetna of Connecticut, they'll reduce premiums in the individual market there by 5 to 20% or 10% on average beginning in September. I mean, that's certainly a welcome change to hear premiums go down instead of up. But are you aware of why Aetna of Connecticut reduced its premium? And, you know, I know your testimony talks about large insurers having a significant amount of built-up reserves, and so they should be able to afford some premium reductions. Is that what's happening with Aetna of Connecticut, or is there some similar actions in the near future that we might see from other insurers?
Aetna is an example of the MLR in action. In order to avoid paying the rebate that they would have been required to pay as a consequence of not meeting their MLR target, they lowered rates. And they wouldn't have lowered rates if they weren't in a position to do so.
Okay, and are we likely to see that with other insurers?
I think so, and I think what's important is that while we, along with others, point out the importance, $2 billion in rebates could come to consumers. The fact is the MLR is not designed to produce rebates. It's designed to produce a more efficient industry and lower premiums.
All right. Mr. Gardner, I think I have time to ask you a question. As you know, the experience of small business with unrelenting health insurance rate increases is not surprising nor uncommon. Since 2000, premiums for employer-sponsored insurance have grown 3 times as fast as wages. These increases are crippling America's small businesses, in my opinion, not health reform. Over half of the small businesses in the country can't afford to offer health benefits to their employees. This means the majority of uninsured Americans are small business owners, their employers, their employees, or their families. In your testimony, you talked about a small business owner who was quoted a 160% premium increase from his carrier last year, forcing him to change plans. So my question is, can you talk about how different insurance reforms and the exchanges, in the Affordable Care Act will help lower premium increases over time, with regard to small businesses?
I think one of the special problems that small businesses have faced, while everybody sees, medical costs, premium costs going up in the country, and it's very well documented what that rate, small businesses are much more subject to a very much annual volatility. And, and every time we have a meeting, there's always somebody standing up talking about what their premium went up and other people chiming in. And a lot of times they can't even find out why their premium went up. When, we're talking about people in the small group market, it's even more volatile if you're self-employed. If you're one of 22 million self-employed, you experience even more premium volatility. And I think we're not really going to see that premium volatility come down until the exchanges are up and going and combined with the insurance reforms. At that point, we're going to see an ability to level them out. So I think the main thing we hear from small business owners is, could we get these exchanges going sooner? Because that, we're going to have to bring those elements together of the exchanges and the insurance reforms before we'll decrease that volatility on a year-to-year basis.
Thank you very much. Thank you, Mr. Chairman.
Chair, thanks, gentlemen, and recognize the gentleman from Louisiana, Dr. Cassidy, for 5 minutes for questions.
By the way, I enjoyed our time we had together. I feel like I have my own exclusive panel, so I appreciate that. Now, I'm intrigued that you brought up Massachusetts, because frankly, Massachusetts concerns me, if you will. That appears to be the prequel, someone described it, the beta version of Obamacare. I'm sorry. Massachusetts appears to be the prequel or beta version of Obamacare, and their small group market has the highest premiums in the nation. Now, they started off with an unemployment rate, uninsured rate of about 10%. Now it's about 4%. And the economic drag of something has been incredible. Maybe it's not this, but they've actually had a negative job growth. I did see that they had a crackdown on their MLR, but those are nonprofit insurance companies. If you talk to the providers and the insurance companies, they say effectively this is like the Soviet Union, that they're being ignored in terms of their true expenses. It's just arbitrarily being decreased. Clearly, you disagree with that, so I just would like your response to those kind of assertions.
I mean, I don't want to spend a lot of time on Massachusetts itself, because I was simply citing it as an example of rate reductions that have come about because of prior rate approval or because of insurance regulators stepping in. And so you see that in multiple cases. Certainly California had very large rate increases, 39% that went to 14% in 2009. Looking at North Dakota recently, 20%.
Can I ask you then, just
Sure.
knowing that those exist, but obviously we're going to differ, may differ in terms of it. My also concern is I'm still a practicing physician in a public hospital. And it's always been my observation that politicians overpromise and underfund. And there's this populist pressure of do something about climbing premiums. Do you see any risk that in the future some DHH secretary, whatever she is, secretary, will say, no, thou shalt not increase your premium. We're going to disregard this cost structure because, frankly, it's a political pressure. It's the year before a presidential reelection, for example, and there's a political pressure to reject such a wage increase. Do you see no risk in that?
I don't see any risk in that because there isn't any demonstration that that's occurred to date. There's 22 states that have prior rate approval. Mentioned the California example of auto.
Now, wait a second. I think we can look at property and casualty rates in Florida and see that there was a political response to something which, people objected. You're raising our premiums. The actuaries for the P&C company said, no, this is reasonable. We have a huge exposure here. So now you may argue whether citizens in Florida was a good thing or a bad thing, but clearly that was a political response to an outcry which actuaries say is fiscally unsound. So there does seem to be precedent for this.
I don't think that there's any significant precedent. What there is a substantial history of regulators taking, whether it's on both sides of the aisle, taking a cool look at rate hike requests and making judgments based on the merits.
Let me ask you,
it's important.
I have limited time, so I'm sorry, I didn't mean to be rude.
Sure.
Dr. Harrington, how would you see where I'm going with my line of questioning. What are your observations?
We haven't had a lot of detail. We haven't had detailed statistical analyses of the relationship between regulation and health insurance and performance metrics like premium growth or loss ratios and the like. There have been dozens of studies of the impact of rate regulation in workers' compensation insurance and automobile insurance. You can have environments where an insurance company in an environment of rapid claim cost growth will ask for 10 or 15%. In a politicized environment, maybe they can negotiate a rate increase of 8 or 9%. That can go on for a period of time. It reduces the company's incentive to write new business. It reduces their incentive to provide good quality. It reduces their financial strength. But it cannot persist. The studies that have looked at long periods of time show that basically there is no difference by type of regulation in these markets, automobile and homeowners insurance. Now, I can't attest to that in health insurance because people haven't looked at the data. But I don't think you can look at anecdotes for what happened in Massachusetts, for example, because in the short run, companies will take a rate increase less than the actuarial projection if the alternative is enormous legal fees, chaos, or having to leave a marketplace. I'd also just like to say we need to keep our facts straight. The California situation was highly publicized. The 39% was touted all over. The weighted average increase was 25%. It eventually was only 14%, and there was that dispute about the numbers and so on. But it's not right to compare 39% to 14%. And it's also not right to assume, as I said, in a particular year, if you get a lower rate increase because of some regulatory action, that that's really consistent with the underlying cost of the business and the long-run viability of the company.
Thank you. Thank you very much. I'm out of time almost. I yield back.
Chair, thanks, gentlemen. Recognize the gentleman from California, Mr. Waxman, for 5 minutes of questioning.
Thank you, Mr. Chairman. Ms. Hayes, Republicans have repeatedly claimed that the administration's rule on grandfathering plans will lead to people losing their plans. Is that true?
Is it true that Republicans have claimed that? Is that the question? I'm sorry.
No.
Is it true that they will actually lose their plans? No, Mr. Chairman. I think that I'm sorry, Mr. Chairman, that was a slip. I'm sorry. I
won't hold it against you.
Okay. And I apologize, Mr. Pitts, for that slip. No, the grandfather rules were established to provide a transition for health insurance. And first of all, starting with the premise that an individual can keep their health insurance, with all due respect to the administration, is a false premise to begin with, because any day an insurance plan could decide that they're no longer going to offer in that market.
Right.
And it's not so much that an individual, I believe, is so much attached to an insurance policy to begin with, or an insurance carrier in particular. They're worried about whether or not they can continue to see their health care providers. They're worried about whether or not it's affordable. They're worried about what benefits are covered. And under the grandfather rules, plans are required to meet certain standards, but frankly, if the plans change their policy so that they no longer meet the grandfather provisions, that's not the same policy anymore either. Because if they're losing grandfather status, they've made a significant change in their benefits. There's been a significant increase in cost sharing for beneficiaries. There's been a reduction in benefit coverage generally. So the grandfather rule per se does not, it protects individuals, and they can continue to keep the plans they have so long as the carriers continue.
Right. Well, do you think employers, would you say employers won't drop coverage just because they may not qualify for their grandfathering?
Oh, absolutely not. I think clearly every employer group that I have heard has said that they want to continue to offer health care benefits because it's an important tool for recruiting and retaining personnel. At the same time, there are provisions in the Affordable Care Act.
Let me move on to some other limited time I have, because I wanted to ask Mr. Gardner. Republicans continue to say, and this isn't a question of whether they continue to say it, I'm asserting that they have said over and over again that the Affordable Care Act will cost small employers too much. However, we know this is not the case. The ACA contains multiple provisions aimed directly at reducing health care costs for small businesses and ensuring that the small businesses, their employees, will have access to affordable and quality health insurance. In your testimony, you discussed some very important provisions that are already helping millions of small businesses. For example, you talked about the small business tax credit that offers a credit of up to 35% of their health insurance costs. 4 million small businesses are eligible for the small business tax credit, and early evidence suggests that many are already benefiting from it. And according to a survey by the Kaiser Family Foundation, the percentage of small employers offering health coverage has risen from 46% in 2009 to 59% in 2010, in part due to the reform's new tax credit. Can you please elaborate on how the health care tax credit for small businesses is helping create jobs and health security?
Well, the direct linkage between the health care tax credit and any tax credit is if more money is flowing into the treasury of a small business, then they have more money to invest. The package for jobs is the fact that over the last decade, 70% of the net new jobs have come from small business. And you know, there's a lot of other industries out there, and they invest in a lot of mergers and acquisitions and increase dividends and go offshore and everything. But really, you know, small businesses are there because somebody was an entrepreneur and they had a dream and they want to pursue that. And they pour their lives and their money back into growing their business. So when we say that they can get a 35% tax credit that's going to reduce their costs, that's going to stay, you know, in the treasury of their company, and they're going to be looking at how to expand
Before.
And as a follow-up to that, what if a state has never had to deal with the MLR? It seems to me it might face an even more significant effect on the insurance market.
I would think that that would be absolutely true, not only from the small employer, but also from the carrier point of view, where a state that has no MLR currently in effect, effectively what the companies are doing is going from 0 to 60 immediately, or I guess 0 to 80 or 85 overnight. If a state has no medical loss ratio now, then it's in effect at the federal level for policies that were in effect before the statute was effectively signed. So there's a retroactive application of the medical loss ratio, and in a state that where there hasn't been an MLR, I think that climb is really steep for the carriers.
Thank you. I conclude from the questioning and from the testimony that it's unlikely that the President's promise that Americans can keep their health plan if they like it is not accurate, and I think we have to move in the direction to making that possible in the greatest number of situations. Thank you, Mr. Chairman.
Chair, thanks, gentlemen. Yeah, that's first round.
Just the three of us.
Yeah. All right, we'll begin a second round of questioning here. Mr. Fensholt, in your testimony, you state that employers' biggest concern about PPACA is the massive administrative burden imposed by the law. Do you believe that the health care law's administrative burden is merely a short-term issue for employers as the law's implementation has begun, or will the law present additional administrative headaches for job creators down the road?
Oh, it'll definitely be the latter, Mr. Chairman. This is an ongoing trend at the federal level with regard to health insurance and the administrative burdens that federal rules put on plan sponsors. And I might add that by 2014, for example, employers are not only going to have to comply with the panoply of existing obligations, but they'll begin reporting to the insurance exchanges the various levels of coverage they're offering to their employees, what they're charging for it, who's eligible for it, who's enrolled in it, and do this on a regular basis, along with a variety of other reports and obligations. The irony about these reporting and disclosure obligations is that if you look at any one of them individually, they may not appear all of that onerous, but in the aggregate, none of these obligations is a sword thrust to the heart. But in the aggregate, you're asking an employer to supply more than 50 disclosures, notices, and reports to the federal government. I mean, over time, this is death by 1,000 cuts to employers. And I will tell you, sir, that we have clients who are at the end of their rope. Their view is this is just becoming too hard, too complicated. The penalty acts hanging over our head is too severe. We're not going to want to do this much longer. And rather than making that burden easier, health reform makes it harder, more complicated, and more cumbersome.
Thank you. Ms. Hayes, in a December 14 editorial, Secretary Sebelius and Attorney General Holder wrote, quote, "It's essential that everyone have coverage. Imagine what would happen if everyone waited to buy car insurance until after they got in an accident. Premiums would skyrocket, coverage would be unaffordable, and responsible drivers would be priced out of the market," end quote. Yes or no? Do you agree with Secretary Sebelius and the Attorney General that if the individual mandate is unconstitutional, would premiums skyrocket?
If it is struck down, would premiums skyrocket? I believe that if the individual mandate were not a part of this law, it would be more difficult for insurers to meet, it would be more difficult for insurers to continue to operate, yes.
So it is fair to say that you believe that if the individual mandate were not in the bill, that would impact other parts of the law?
Yes.
Medicare's plan to prevent fraud and abuse has often been described as a pay and chase model. Can anyone please describe how pay and chase anti-fraud efforts work? Ms. Rochelle?
I'm seeing people looking down at my end of the table. What pay and chase means is that once a service has been provided, the bill has been sent to the insurance company has paid it, there is a retroactive application, if you would, or an attempt to get the money back that somebody finds out after the fact has been provided fraudulently for a service that didn't occur, for a service that shouldn't have occurred, for somebody who isn't there. And that's pretty much what a pay and chase is, as opposed to preventing the fraud from occurring in the first instance.
All right. I'm going to, at this time, yield 5 minutes to the ranking member for his questions, since we're voting.
Thank you. Have we started the vote? Yeah. Oh, okay. I'll try to be quick. I wanted to ask Ms. Hayes about the waivers. You know, Republicans, they spent a lot of time complaining about the inequities in the waiver process for annual limit requirements. They made allegations that favored political allies of the Democratic Party, particularly unions, were being exempted from all the health reform bills, consumer protections, and insurance regulations. And I think these claims have been widely disproven. I don't think they need a lot of consideration here. But, for instance, union plans were more than 5 times more likely to be rejected for annual limit waivers than were other kinds of applicants. Moreover, waivers for annual limits policies affect only a small number of people and are just one consumer protection in the law. Your testimony describes the waivers as a kind of transitional policy from today's world to a much more rational insurance regime in 2014. Would you just elaborate on that a little bit?
Yes, sir. I have seen no evidence to suggest that the administration is granting favors to anyone when it comes to waivers. Clearly, Congress anticipated and were warned during debate that there were going to be transitional issues, and that is built into the law itself. So I don't find it particularly surprising that waivers have had to be granted, and particularly in the area of some of the mini-med plans that you've seen out there, which I don't think anyone would argue are allies of the current administration.
All right, thank you. I'm going to ask Mr. Gardner and Mr. Rome. This is about the Affordable Care Act creating jobs, because I obviously believe that it creates hundreds of thousands of jobs. But the opponents make strong claims that the law will kill jobs. They argue that requiring employers to offer health insurance and to improve their benefits will increase costs of labor. I don't think that's true, because I think the ACA is in fact helping to create thousands of jobs in the public and private health care sectors. In June 2010, funds were allocated to train more than 16,000 new primary care providers, including physicians, nurses. It seems logical that the newly insured 30 million people will need doctors, nurses, and other health care personnel to meet their medical needs. I know the Republicans have said that the country may not have enough doctors and hospitals to serve these people, but the answer to that is to grow the workforce and create more jobs. I just wanted you to comment, one or both of you. Can you describe for us how the ACA is a job creator, not a job killer, and talk about some of the other factors, just to comment on that? I'll start with Mr. Rome, I guess.
Okay, I would just say two things before Mr. Gardner. I mean, one is that one of the best things that we can do to help create jobs is reduce the expenses that employers face. And reducing health care costs is an important and significant part of that. And that's why the MLR, for example, which makes insurance more efficient and more affordable, is an incredibly important part of job creation. Second thing is when we do talk about medical personnel, simple example, over the next 10 years, community health centers are going to go from treating 20 to 40 million people, and that is a substantial change in treatment, and that will obviously create jobs in the health sector as just one example.
Mr. Gardner?
Well, where we start from is, what if we don't have health care reform? That's what we see as the job killer, and that was the study that we had done by MIT to start with. So we start from the premise, if we don't do something about the ever-escalating, we're going to lose jobs, and we documented that as 178,000 jobs. I think that's a very conservative number. But if we go forward with health reform and reduce costs, then firms can invest that money. And in fact, the other part that we have to look at is job lock. You've got 42 million employees at small firms, under 100 employees, and it's been well documented in the literature out there that people can't leave because they're worried about getting their benefit. Of course, this would be any size firm because they don't know if they're going to have health care where they go, especially when we have half of the small employers not providing it, and that's a shrinking base. But so employees can't move, they're unhappy, everybody who's been an employer knows that that's not a good thing, that when an employee wants to move, they ought to be able to move. But it also applies to people starting companies, entrepreneurs. Why is somebody going to take the risk to leave a good job with good benefits and go out there and be a self-employed person, a startup company, and then find out how expensive and how unattainable health care might be for them? So there are several ways that having health care available and having it more affordable and less volatile is going to help small businesses grow and make it easier for people to start companies.
Thank you. Thank you, Mr. Chairman.
Chair thanks the gentleman. That concludes our first panel. Chair thanks the witnesses for their testimony, for their patience. Despite the interruption, it was an excellent panel, excellent testimony. The subcommittee will take testimony from the second panel at a date to be determined. The subcommittee is now recessed.